By definition, a health priority can be a specific health challenge for a certain population. The Aboriginal and Torres Strait Islander population is considered a priority due to prominent health conditions and access to healthcare in regional or rural settings. It is a worldwide phenomenon that most Indigenous populations are considered with lower health standards compared to non-Indigenous groups. Poverty, malnutrition, overcrowding, poor hygiene, environmental contamination, and prevalent infections are associated with poor health conditions. Outcomes can be greatly affected by access to both adequate healthcare and disease preventative services. In Australia, colonisation is the initiating radical to this big health gap between Aboriginals and Torres Strait Islanders and non-Indigenous Australians. Evidence suggests lifestyle diseases are common amongst Indigenous people transitioning from a traditional to modern lifestyle. As a result, positive changes should be encouraged and committed to in order to overcome these challenges and set higher standards of health for disadvantaged populations. Many Indigenous Australians suffer from poorer health than non-Indigenous Australians. Evidently, studies by the AIHW show that they have a lower life expectancy of approximately 10 to 17 years on average. It is aimed to close this gap between the two parties to improve the health and lives of Aboriginals and Torres Strait Islanders by reducing the disadvantaged state. There are three major underlying causes of this health gap. The first being chronic diseases, which show a high prevalence in Indigenous Australians, accounting for approximately 2/3 of total health burdens compared to non-Indigenous Australians. These chronic diseases include cardiovascular disease, diabetes, mental disorders, and chronic lung disease. Mental and substance use disorders are more prone to occur in Indigenous Australians. Statistics show this to contribute to 19% of the total burden. Of course, there are other major contributors such as cardiovascular diseases, cancer, respiratory diseases, musculoskeletal conditions, and other self-inflicted injuries. Social determinants are considered to be the major influence of poor Indigenous health. These are the disadvantages caused by poor health outcomes directly or indirectly. These factors include poor education, unemployment, low income, discrimination, and poor quality housing. The AIHW analysis of the 2008 survey by the NAT-SIS and the NAT-SIH show those who had completed Year 12 were significantly less likely to smoke than those who had not completed Year 12. It also shows people who are employed were most likely to smoke than those who weren't. We can conclude that Year 12 completion was associated with a lower probability of risky alcohol consumption and sedentary lifestyles. Finally, poor access to effective healthcare services by Indigenous Australians is often consequential from a range of factors. Some examples are long waiting periods, lack of immediate attention or care, insufficient facilities in the area, and services not culturally appropriate. Inability to access proper healthcare treatment may potentially instigate reasonably high rates of hospitalizations that could have been prevented by access to appropriate health services. The AIHW data shows during 2010 to 2012, Indigenous Australians were 3.5 times as likely to have a potential preventable hospitalisation than non-Indigenous Australians. So it was and is a major issue.
Thank you, Yasmin. When considering the Aboriginal and Torres Strait Islander or ATSI population and its health priority, we must acknowledge the key stakeholders involved. These include the Aboriginal Torres Strait Islander children or teenagers, Aboriginal adults, and the government or council. Aboriginal Torres Strait Islander children and teenagers are crucial in the discussion of this health priority. Modern education and media are a source of information. Hence, the westernized medical practices that are taught to the younger generations of the Indigenous people are a stark contrast to the traditional medicinal values of the Aboriginal and Torres Strait Islander people. It is through this that a child's acceptance within the community or tribe will be challenged. This decision becomes one of belief and will factor in the overall health of this population. Westernized medical practices are beneficial as they facilitate the proper care and treatment effectively, whereas traditional Indigenous practices are beneficial in their own sense, in that it extends the beliefs of the Indigenous and instills these cultural values within a developing mind. Additionally, the health decisions made by the youth factor in the overall statistics of the Aboriginal and Torres Strait Islander health, due to behaviours such as adolescent smoking and unsafe sex. However, studies have established that empowering communities to work with the Indigenous youth on preventative health is benevolent in aiding children in developing a positive sense of self and promoting good social and physical health. Aboriginal and Torres Strait Islander adults are also significant stakeholders in this priority, as they are essentially the deciding factor for Indigenous health. Indigenous adults will usually be traditionally oriented and will stray from modern medicine. The Indigenous people have a traditional medical system that focuses on preventative care based on laws that govern behavior, for example, obeying ritual prescriptions and taboos. Bush medicine and traditional healers are the significant treatments that have similarities to modern medicine, but perhaps may not be as effective. A considerable proportion of the Aboriginal population lives outside of the metropolitan area. This separation is monumental to consider as access to health and isolation factors in the health of the Aboriginal and Torres Strait Islander population. This acts as a detriment to those Aboriginal adults that perhaps acknowledge that they require modern medicine for treatment, but are unable to seek it because of geography. Hence, Aboriginal and Torres Strait Islander adults hold the primary responsibility to accept or deny modern healthcare based on culture or geography, as this has implications for the entire population, making them key stakeholders. The governmental council are providers of healthcare and hence are key stakeholders in the health outcomes of this population. The government holds resources that will improve the health rates of the Aboriginal and Torres Strait Islander population, such as access to care in rural or regional areas, technology, medicines, and skilled health professionals. Initiatives and health programs involved in promoting healthy medical practices within Indigenous and rural settings, boost positive statistics and rates. These initiatives work to improve the prominent health priorities within these Indigenous communities, these being sexual health, disease, tobacco use, and cancer. Examples of initiatives and programs include the National Tobacco Campaign with the Break the Chain and the Pregnant Woman Targeted Quit for You, Quit for Two advertising, which are directed at tobacco-using Aboriginal and Torres Strait Islander people. The Care for Kids' Ears initiative creates awareness of ear disease within these communities and stands as a preventative measure, much like other programs instigated by the government. However, non-government organizations will also stand as a driving force for prevention and aid. A major candidate in this, as Varshana will go on to cover, is a Close the Gap campaign, which consists of NGOs and human rights organizations that aim to achieve health equality for Aboriginal and Torres Strait Islander people, and essentially close the gap to healthcare. Over to Varshana, who will now be speaking about how this health priority is being addressed.
Thank you, Swati. I will now explore how this health priority has been addressed. As previously discussed, there is a stark difference between the Indigenous and non-Indigenous health. This is due to a deprived access to the basic human right of health equity, which has in turn affected physical, mental, and cultural well-being of the Aboriginal community. Past incentives have been ineffective due to barriers such as inadequate resources, funding, and minimal engagement of the Indigenous community into their own health. Overcoming these concerns currently involves a complex network that integrates all the key stakeholders involved. This approach was made concrete by the 2016 Closing the Gap campaign, which aims to provide ongoing focus and scrutiny on the health inequalities faced by Indigenous Australians in order to reach their goal of closing the health and life expectancy gap by 2031. But how is this goal achievable? Oxfam claims this campaign created the opportunity for a partnership amongst Indigenous advocacy organisations such as AHMRC, the government, and the Indigenous community. This partnership has facilitated the development of policies and programs to integrate all aspects of Aboriginal health. However, yearly progress reports question the effectiveness of this campaign to effectively diminish health disparities. They reveal that closing the life expectancy and child mortality gap to be the only goals on track to meet their deadlines. Statistics reveal chronic diseases to be largely responsible, whereby cancer mortality rate continues to increase. However, I would like to highlight here that despite slow progress, patience is key as several organisations have since emerged to support Aboriginal health. I will now be focusing on how issues surrounding cancer and remoteness in this population are currently addressed. So, statistics surrounding cancer reveal that from 1998 to 2015, age-standardized mortality rates have continued to increase over time. The high prevalence of poor lifestyle habits such as smoking and alcohol abuse may be the cause. Cunningham and others revealed that Indigenous Australians also have a higher incidence of preventable cancers and are less likely to undergo treatment. To address this health concern, AHMRC is currently partnered with several cancer organisations to develop projects that aim to support and inform patients, as well as prevent cancer in the Aboriginal community. One of these projects is the Kick the Habit campaign, which aims to break smoking habits. These programs are useful, however, they often have limited integration of Aboriginal beliefs and perspectives that could encourage greater compliance to Western medical services. Evidence-based practice is also emerging in the improvement of this Indigenous health priority. Charlie and others found cultural and spiritual beliefs to affect decision-making in health. Christina will later expand upon this idea. So, lacking access to appropriate care is another issue affecting the health of the Indigenous community. As shown, most of the Indigenous population live in regional and remote areas where they have limited access to quality healthcare, whereby statistics reveal these regions to have poorer health in relation to lifestyle diseases, life expectancy, and infant health. To overcome this health concern, the Royal Flying Doctor Service was developed to deliver timely health hospital care through aeromedical transport. They also provide a clinic program to provide access to healthcare in remote Indigenous communities. To summarize, several health initiatives exist to overcome the health disparities between the Indigenous and non-Indigenous population. However, they can truly be diminished in an ongoing collaborative effort that focuses on respectful engagement and empowerment of Indigenous people. Christina will now discuss how this may be achieved.
Thank you, Varshana. It is important that we consider the future of healthcare for Aboriginal and Torres Strait Islander people as we move towards a national wellbeing status of balance, fairness and overall comfort and accessibility. The Australian Government has implemented a 10-year National Health Plan for A and TSI people, hoping for an overarching goal of targeted, evidence-based action that will contribute to achieving equality of health status and life expectancy between Aboriginal and Torres Strait Islander people and non-Indigenous Australians by 2031. Of the many focus plans in the advancement and improvement of both A and TSI health, as well as the healthcare system, the refinement of health system effectiveness and clinically appropriate care seems to take on particular importance. The Australian Government and affiliated councils wish to achieve a level of Indigenous care that is clinically appropriate yet culturally autonomous and respective of the same quality as the care provided to non-Indigenous Australians and widely accessible. It is important to note that A and TSI people access health services at 1.1 times the rate of non-Indigenous Australians, even though their need for health services is estimated to be 2 to 3 times higher due to their poorer health status. And as such, a need for health services to be more involved in the surrounding communities can be quite integral to the future health outcomes of the people, who can feel comfortable in knowing that their health service providers are willing and encouraging the cultural and social needs that can be attributed to health. There are many key strategies in achieving this goal, including prioritising the development of primary healthcare systems, improving access to health information via e-health, and recognising that for some patients there may be a transportation or language barrier that may inhibit their experience of a healthcare service. The integration of evidence-based practice within the Indigenous clinical setting is another goal aiming to be achieved by the Australian Government. This provides better access to health records utilised by both patient and clinician. These programs attempt to focus on patient-centred care by involving the patient in clinical decisions and remaining autonomous in the instance of a complementary, culturally based approach suggested by the patient. Clinical researchers often underestimate the health impact of the A and TSI people because they use fragmentary or inaccurate data. By supporting the skill development of the ANTSI people, we can get them to actively participate in and conduct their own research in relation to their own culture and societal beliefs. Therefore, the initiative of valuing and respecting Indigenous people and their beliefs and practices is crucial in evidence-based practices and research. Although these initiatives have been attempted by the Australian Government, other organisations centred around the improvement of Indigenous care also play an essential role in the grounding and support of these plans. For example, the Australian Health and Medical Research Council represents and advocates for ethically sound initiatives involving the Aboriginal people and the wider Indigenous community. In essence, the support of priority-focused organisations such as the AH and MRC can in fact improve the chances that these health plans and goals are achieved and are continually implemented even after the timeline for the National Health Plan is over. In conclusion, Indigenous health is a contemporary health priority because the difference in health outcomes, systems and care between Indigenous and non-Indigenous people still continues to be markedly significant. The ability for ANTSI people to be comfortable with seeking out health services is integral to large-scale initiatives such as Closing the Gap, and this is attempting to be done by implementing evidence-based practices and patient-centered care approaches. Through programs such as these, we hope to encourage Indigenous people to actively engage in the patient-doctor setting and feel comfortable enough to express their beliefs associated with their complications, as well as provide high-quality health services which are easily accessible, culturally and socially appropriate and affordable.